last week a couple of concepts. You may even see some stuff talked about in the patient care class as well, but all of it's just gonna be a review for you guys. So what is our role as a technologist when it comes to mobile fluoroscopy? So we did talk about this last week, the difference between a fixed and a RF room. We said a fixed room was just a room that had mobile fluoroscopy equipment in it. A RF room, you're able to do X-rays and fluoroscopy. It had the equipment to do both. Your radiologist is going to be your primary operator. They're going to control the tower, the table, and they're going to be the ones taking the exposures. So technologists, we are considered a secondary operator. We basically assist the radiologist. We prepare contrasts. We talk to the patient about history and prep. We administer contrasts as needed, and then we assist with the patient positioning. So with our C-arm, which we use in the surgery setting, maybe in interventional, will be the primary operator in the eyes for the surgeon. Like I said, the C-arm is typically used in surgery. That's going to be the main place that is used. It can be used in interventional, sometimes in GI lab. So it can be used in different areas of the hospital. Sometimes the cath lab, they may have a C-arm, endoscopy, and to do cystography or urinary exams. It can be used in those settings as well. So as you guys get closer to the end of the program, you just need to know that there are requirements for mobile fluoroscopy comps. So you'll be required to do 2 mobile fluoroscopy comps for your ARRT. So you'll have to do your C-arm procedure, and it requires you to manipulate to obtain AP and a lateral view, or a surgical C-arm requiring you to manipulate the sterile field. We talked about sterile fields. I know we talked about it in patient care about, starting a sterile field, where the sterile field is, how to set up, kind of a sterile tray. So we kind of talked about all those, but just know that for ARRT, you will have to have 2 mobile fluoroscopy comps. So the biggest place that mobile fluoroscopy and the C-arm is used is, like I said, is going to be surgery. So in order to work in surgery, I do think it takes a special kind of technologist to do that. Surgery was not my favorite, not my favorite place to be. Number one, it's cold. A lot of times it's freezing, and I don't like being cold. And just kind of the unexpectancy of what can happen, and the doctors being under pressure. I just don't like being under pressure like that. But in the surgery setting, you have to be a team player. So it's important that as a team you work together. You have to know the hospital surgery policies and procedures. Main thing in there is just making sure we keep everything sterile, and make sure our equipment is covered properly, and make sure everybody is protected. So make sure everybody is covered in lead or is behind a lead shield before we make an exposure. The biggest thing we do is going to be set up the equipment and operate the equipment. Getting in there to kind of figure out what the surgeon is going to need, understanding, your angles and what's going to be expected of you during the procedure. And then having excellent communication. You almost have to, sometimes you have to anticipate the next move in surgery. Once you're in that environment and you work with a specific surgeon, you probably can kind of anticipate what that person is going to want or do next. But one big thing they do in surgery is timeouts. So that's the way they identify their patients, making sure we have the right patient and we have the right side or site to operate on. So your surgical team is divided up into two groups, your sterile group and your non-sterile group. So your sterile group is going to be your surgeon, your first or second surgical assistant, which could be a PA, a nurse practitioner or RN, and a scrub tech, who could be a RN, a LPN, or a certified scrub tech. And then you have the non-sterile group, which would be your circulating nurse. Your circulating nurse really just kind of circulates. She does like charting, and she just makes sure if like the doctor needed something that's not that's not on the table or that's not in the room, then she can kind of, help out. More like she's like a runner, a standby. Your nurse anesthetist, which is your CRNA, or your anesthesiologist. Either one of those can be in there. A perfusionist, radiologic technologist, and even a medical device rep. Any one of these non-sterile people could be in a case at any time. So that's your non-sterile group. What you would wear when you're in surgery. So because surgery is the environment that it is, everything has to be sterile. You can't just walk in there with your scrubs on and start working. So one thing, uh, well, you can walk in with your scrubs, but it's other things that you have to have on when you go in there. You always want to make sure you have scrubs. Some people will require you to wear a surgical gown, depending on what you have going on. But of course, the surgeons and the nurses that are going to be involved in the procedure are going to have a surgical gown on. We should have masks on just like everybody else. Surgical caps. This is suggested if you have, for everybody, especially if you have long hair, getting all your hair up and out of the way. Gloves and shoe covers. Gloves, I say always use gloves. You never know what's gonna happen in the surgery. Shoe covers, we tend to spend a lot of money on our work shoes, whether you have an expensive pair of comfortable tennis shoes or you wear like dance goes or some other shoe like that. Those shoes aren't cheap. So using shoe covers just to be on the safe side. Just remember the hospital floor is probably one of the dirtiest floors ever. So and then we come home and have those shoes. I usually take my shoes off at the door when I get home. I don't walk in my house with the shoes on or leave them in the garage. So, because you could be in a case that has blood or bodily fluids, and depending on you, it may get on your shoes. You might not even know. So, and then C-arm cover. So that the C-arm cover is for our equipment. So it is our responsibility to make sure that our equipment is number one, cleaned and also covered. So usually the sterile cover for our machine, the person that's running the sterile field will have a big plastic looking bag, and she or he will help kind of get that covered. We usually touch the inside of the bag and kind of pull it down so we can get it all situated. But we always have to have that cover over there. Is usually a big plastic bag, and it's our responsibility to do that. It, like I said before, it is also our responsibility to make sure everybody is protected before the radiation starts. So everyone should have their radiation monitors. Everybody should have a lead apron on. Usually the surgeons they'll have their apron on up under their gown. Um we need to verbalize exposure. So you need to say something when you're getting ready to hit the button. So usually we say X-ray, so everybody's aware. Being aware of source to image, our SID and our OID, because that can affect patient dose. Magnification, limiting that feature, because we learned that magnification does increase three things. Does anybody remember what magnification increases when we use that function?
Patient.
Somebody started to speak, but their mic cut off. No words, Ireland.
Is it the field of view?
Not quite. So think about when we magnify image, um, we're zooming in. So what things or factors do we think that it affects? Or basically all three of these factors increase when we use magnification.
Patient dose,
That's
brightness.
yes, that patient dose is the biggest one.
Would it be brightness too as well?
Contrast, yes.
Okay, contrast.
And then also spatial resolution. So those are the three things that and that's one reason why we try to minimize our use of that. Anything that's going to increase our patient dose in surgery setting, we want to try to do. And then also collimation. Collimation is another way we reduce patient dose, and there are buttons on the machine that allow you to collimate. So just for you guys to know and understand, the patient is going to be your greatest source of occupational dose due to scatter. So, we're not in a room in our department where we can stand behind a lead shield and, hit an X-ray button. And then also our equipment is different. And our fixed rooms in the department, your X-ray tube is above the patient, and your image receptor is going to be below the patient. And then you have a bucky tray, and you have things to help, kind of absorb that scatter. But it's a little bit different in the surgery setting. So just remember, the patient is going to be the greatest source of occupational dose due to scatter. So how can we reduce patient dose? Beam restriction, the collimation. So making sure we collimate when we can. So the less area covered or the less tissue irradiated, the less dose to the patient. Using pulsed versus intermittent fluoroscopy. So your pulse fluoroscopy is basically which there's a button that you can set, is delivered in short pulses instead of like a continuous stream. And this does tend to lower dose, this mode, and it's usually used when you have like longer procedures, or if you have procedures on children or pregnant patients. It's really up to the depending on the type of case you're doing, and up to the surgeon, their preference, what they like. And then you have intermittent fluoroscopy. This is basically where the operator manually switches on and off. So either you have the dead man switch, which is the foot pedal, or you press the button on the machine and you're basically operating the X-rays. So with pulse, you have 5 versus 15. You may have 5 less exposures versus 15 more exposures. It just really depends because you can set that on the machine. And intermittent can be a dose saver, but it just depends on how often it's going to be used during the procedure. Then our source to skin distance, which this is our distance between the x-ray source and the skin of the patient. So we know our x-ray source is going to be on the bottom. The minimum for fixed equipment is about 15 inches, which is 38 centimeters. And the standard for mobile is about 12 inches, and that's the 30 centimeters. And when you think about source to skin distance, that C that's open for the C arm, that's kind of where that is going to come into play. Like we said, limit magnification, and then using the 15% rule. So the fluoro machine will really give you the dose that you need. But for some reason, if when you hit the fluoro button, it doesn't come out the way it should, or it's grainy, you can always use the 15% rule. The 15% rule is that if we increase our KVP by 2, then we can drop our mass. We can halve our mass, and vice versa. So if we up our mass, then we drop our KB. So that's pretty much the 15% rule. Really, with fluoro, you won't have to do a lot of adjusting, because like I said, the machine kind of is the brains. And unless you have a patient who's a little bit bigger, the machine, and you're centered up pretty good, the machine will usually give you the right technique. So how do we reduce occupational dose? Of course, with shielding. In these areas, you usually see people wearing lead aprons, lead glasses, lead gloves, and a thyroid shield. So you're protecting those sensitive lenses of your eyes. You're protecting that sensitive thyroid, and just making sure you're covered. Then your distance, which this is what we're always taught, time, distance, and shielding. Making sure you're at least 6 feet away when you make an exposure. Thinking about the inverse square law, and then always having the machine at a 90-degree angle. And we'll see a demonstration of that, what that 90-degree angle looks like. It's basically the home of how the C arm is set up. Your image intensifier is on top, and your X-ray tube is on the bottom. Let me check. I see some chats. Do I know any good websites to get lead glasses, just in case sites don't provide them? I actually don't. Because usually if you have a radiation safety officer at your department and you request them, they will get them for you. But I know if you're going in, if you don't work there, you're like a student, they usually provide you with, at least if you're going to be doing, you get a thyroid shield, and you can get a lead apron. But you probably can Google lead glasses and find some. They now will tell you they tend to be a little expensive. But you probably can Google any of those, and we'll talk about later in the term about like the minimum protection and lead glasses and all that kind of stuff. But yeah, that's not this is if you're gonna be around it and you're gonna be working in fluoro or surgery, like that is a good investment. So somebody asked about will that be rolled into our extern hours, the comps? So technically when you're at your externship or your clinical site, you should begin your comps. Now I'm I'm not sure how it's set up. I know they have certain sites and they try to put you all places that where they know you need these, you need certain comps. And they look at the types of clinical sites that they have and what you need and what you need to learn. So it'll just kind of depend on where they place you. And if you're lacking in those and you let the clinical team know, they'll make sure they get you to a site where you can see those and get those comps. Okay, exposure reduction at a 90-degree angle. So pretty much if in a fixed fluoroscopy unit or a C-arm, the home is 90 degrees. So with a fixed machine, we know we have that lead curtain that falls in front. That's a type of protection. But if you see that's going around the table, this red is going to be where most of your radiation is going to be. So those are going to be the higher spots. And then as you kind of get away from those, using that 6 feet, then that, it kind of decreases. So no, we don't have a chapter this week. I said that in the beginning. There's not a chapter in either of the books that kind of hone in on just specifically mobile radiography. And everything that I'm talking about tonight is gonna be on the test. So you can use these slides to study for your test. So X-ray tube location and dose. So here's where we get into what's the best or what's the ideal positioning. So the way you want to ideally use the C-arm is that your X-ray tube is at the bottom and your image intensifier is at the top. This is kind of standard. This is the home. Now we know we have to move this so we can get a lateral view. But we want to use this. That's going to be your standard. The X-ray tube above the patient is the greatest occupational exposure to the technologies. And I will tell you, I have never seen anybody do this. There's no reason for you to do it. If somebody is doing this, then they obviously don't know what they're doing, because there's never an instance where the X-ray tube should be above the patient. It may be on the bottom or even on the side, but it's never an instance where it's going to be above the patient. So this is the safest way or the safest position, with the X-ray tube at the bottom and the image intensifier at the top. So here's a cover of those C-arm drapes and covers. Like I said, this is part of the sterile field when we start using it. And you will have somebody that helps kind of get this bag over the C-arm, and you see those rubber bands. Usually the person that's running the sterile field will place these rubber bands. Usually what we do when we have to move the C-arm is that we reach inside of the bag and move it. Some equipment now, depending on what you use, it kind of will do it for you. But that's pretty much how we maneuver it when it's in the seat, when it's covered in a drape. So some sterile versus non-sterile rules. Sterile field, like I said, we talked about how to establish a sterile field. I think in patient care, with sterile team members, you want to pass front to front or back to back. Always remember, from waist to shoulders is where your sterile area is gonna be, and from 2 inches below the elbows down is where it's sterile. So pretty much on this picture in green is showing you the sterile areas of the surgeon. The sterile part of your table is gonna be waist above above the table, waist up is sterile. Anything below the waist is going to be non-sterile. So besides just a fixed fluoroscopy room and then a C-arm, which does include your monitors and your workstation, which has a control panel on it, and we'll kind of go over that in a little bit. You do have many C-arms. You have an O-arm, and we kind of talked about the O-arm last week briefly. And then you have your mobile or portable machines. Portable machines actually can be used in surgery, the surgery setting. Sometimes they're used if they're they have a miscount of sponges, or they suspect that they an instrument they can't find, because they usually count before and they count after. Or if they need a post surgical film, they'll usually call in the portable machine to kind of take a x-ray. The C-arm does have monitors and controls. Your controls are how you produce the x-ray. 3 ways. Your controls, it's either going to be with the foot pedal, which we call the dead man switch. It's either going to be exposure switch, which could be, it's an exposure switch on the machine, like on the very top, but then usually there's a remote. The last time I used the C-arm, it had a tether, like a wire to it, and it had a remote, so you can kind of step further away. I think some of the equipment now has like a wireless, or kind of wireless remote is not attached to it. And then on the machine. So remember I talked about that skin source to skin distance, and this is the free space. So you want to make sure that your patient is kind of evenly centered in there. When you start kind of going up, which if you went up, you're putting the source closer to the skin, or you going down, you taking the source farther away from the skin. You want to kind of be careful, because that can affect patient dose. You do have functions on this C-arm to rotate it, to kind of rotate it, to move it up and down, north and south. And we'll talk about that in just a minute. So an O-arm. So what I will tell you is an O-arm is not a nuclear medicine device. It's not used for nuclear medicine. A O-arm is similar to a C-arm, but it does have a closure on there. It's the C-arm is more 2D, the O-arm is more 3D, and you see O-arms commonly used in spine, orthopedic, and trauma cases, because it does offer a little bit more detail, precise detail. And then you have your mini C-arm. Basically you can see it looks the same, it's just a smaller C. Does the same thing, same functions. Usually it's used for smaller anatomy, like hands and stuff like that, but sometimes you'll see that, and basically the surgeon operates that as well. So once we take the images on the C-arm, how do we see them? That it kind of works the same way that we talked about last week. Those signals are sent to the monitor. Usually you do have 2 monitors. So sometimes you have a monitor on the machine, and then you have a separate kind of work tower that has a hard drive in there, and then it also has your monitors on top. This is where, when you take your exposure, it's gonna come up here on this screen. There are several settings. Usually you can last image hold, you can set it where you take a picture and it holds that last image on there. You can switch the images depending on the way the room is set up. You can put the picture on the right side or the left side, so that can be switched. It's depending on surgeon preference. And the surgeons are gonna use this when they're possibly advancing needles, when they're doing hardware such as screws and pins. If you've ever seen an orthopedic case, those are like my favorite. If I had to do anything, that probably was my favorite, to do orthopedic cases. I didn't like to do like vascular cases. It was just too high stress for me. I just thought the ortho cases were cool because you um got got to see people like relocate dislocated shoulders and stuff, and just to see some of the stuff they do, to see how they actually get pins into a hip or ankle, or how they do a hip replacement. I just thought that was really cool to see that. Like I said before, the control panels. So there are 3 ways to activate the fluoro on the mobile fluoro equipment. You got the machine. Let's say there's a button up there. You have an exposure switch, which is a remote, and then you have your dead man switch, which is your foot pedal. Usually using the foot pedal, you end up, sometimes depending on the surgeon, you end up with more radiation by letting them use it, but it just depends. And what this is the I is gonna be your just regular fluoro, and your I with a plus is gonna be subtraction. Usually they're gonna use subtraction modes in vascular cases, so that's when you'll use that mode. So some common surgical procedures: cholangiograms, cholangiography, retrograde urography, orthopedic procedures like closed reduction, open reduction, internal, external fixation, intramedullary fixation, hip fractures, uh, femoral neck, uh, laminectomies, pacemaker insertion. You'll see those more in the cath lab. Arthroplasty, lithotripsy, you'll see that in urology. And then microdissectomy. So you should have reviewed, if you have not already done your worksheet, there is a video that you should reference when you're doing your worksheet this week. And I put that in the comments in the assignment guidelines. It pretty much goes over each section, kind of telling you what each one of these buttons does. You are able to make exposures from, with, like I said, with the on the equipment, or either with the remote. But if you ever need to adjust any contrast, any technique, if you need to flip images, if you need to collimate, it's a panel on the actual C-arm that you can do all that. So I think the most important button on here is your alarm reset. So usually this is set to alarm at about 5 minutes. Usually it'll do it at a total of 5 minutes. Usually people don't just continuously fluoro for 5 whole minutes. But usually, depending on the type of case, they may get, between using it intermittently, they may get to that 5 minute mark. So a alarm will sound, and you have to set that alarm. So it'll basically reset the timer. You can, like I said, you can flip and rotate your image, collimate, adjust your contrast and brightness, and then also adjust your KVP and your MA. So we talked about that alarm button. I'm just gonna go over these real briefly. Like I said, the video kind of goes over them too. This is, you can change the orientation of your image on the screen. So you can say a patient is laying PA, you can flip the image over, or maybe you're at a weird angle You can flip it up and down as well. You're also able to kind of rotate that as well. So it offers you a way to rotate the actual image on the screen. Magnification mode, we talked about this, using this. Then you have your collimation buttons. You have your this is considered like your iris collimator. You see, it's kind of like a cone collimation. You can kind of cone in. And then also you have your leaf or shutter collimations. And you can actually you can adjust these too. You can rotate them around. So you have your auto contrast. This adjusts your brightness. Remember with what we talked about last week, our ABC is gonna give us our technique. So your ABC is gonna be these buttons right here, and then your ACG is gonna kick in. So your ACG is gonna be this right here. There is an auto button, but you can adjust it if you need to. Then you have your technical factors, like I said, you can adjust your technique. This allows you to use post mode if you just want to quickly hit that, or if the surgeon prefers that. Then you have a low dose option. You can use this if you just get in there and you got a patient that's really, really small, you can hit that. Um, and then most importantly, your alarm reset button. This section right here, this allows you to save the image on the screen. Sometimes the surgeon will say save image. So it allows you to save that image, and then you can kind of upload those images in the packs versus last image hold. Because last image hold is just gonna save it's just gonna keep that last picture of whatever was taken. So when the surgeon hits the fluoro button, whatever that last area was, it's gonna be on the screen. It's not necessarily saved, but it's gonna be on the screen versus they hit that and that image comes up on the screen, and then you hit the save button and it's gonna save for you to upload in the packs, or even for the doctor to come look at a later date or a later time during the surgery. Workstation, so this just means you can put one if you may have an image on the left and they want it on the right, or you have it on the right and they want it on the left. So you can just switch monitors. And then the mode button, this is another way to do subtraction. You hit that button, it'll take you to subtract. You can do subtraction mode. You also can steer, brake, and move this machine up and down, left to right. There's another video you make sure you watch this week that demonstrates all that for people who are more visual learners. That should kind of help you. This is gonna be your steer button. So this is gonna allow you to drive the entire C-arm. So when you're trying to kind of get it maneuvered, you use these handles to kind of push. But then if you need to do any type of steering, move it over to get in the doorway or move it up or down, you use these buttons. And then you have your brake right there. So if you got it parked in a position that you like, or whenever you finish with the machine and you go put it up, you can hit the park button or the brake. Then we have what's called transverse and in and out. So basically what that does is it basically moves the seat in and out. Then you have these two buttons on the top that will move up and down. So this little tower right here, you press that button, it'll move it up. Press the other button, it'll move it down. So it can move up. The height of the C-arm can move up and down. Head to toe or north to south. This is like the steer button. So once you get it kind of parked in the place you need, you may be doing the a cervical spine or an L spine, and the surgeon may need you to go up a little bit more. So this allows you to kind of go from head to feet, head to toe on the patient. Wig wag or swing to head and swing to feet. You have this option. It just makes it a little bit more versatile. It really depends on, where you are, the size of your room, if you have to use that. But if you did use it, here's the button that you would use it with. So when you turn this button, it has a lock. I don't know if you can see it. It has a lock right here and an unlock. So once you turn it to unlock, it'll kind of let you swing it. And then tilt or angle. So this allows you to kind of tilt that seat, take it from a 90-degree angle to a different angle. And this is the button that you do. It's a lock and unlock button on this. So it'll allow you to do a cranial angle or either a cranial cock angle. Then you have orbital or lateral. They call this X-ray or rainbow. This is how we move it into that angle that we need to do a lateral or cross table lateral. So this button right here is what you will use to kind of move it into that rainbow position. It should always be used like this, with that seat under the patient. It should never be with the seat over the patient. I've never seen it used like that. It never should be used like that. It's always going to be the seat under the patient. And then orbital or lateral that you do obliques, similar to this one right here, the cephalic and caudal tilt and angle. It'll kind of let you do shallow angles, more deeper angles, depending on what the doctor needs. Okay, that's all I have for you guys tonight. Do y'all have anything for me? Any questions?
On the lateral C-arm, would the X-ray tube be facing us, or would it be facing the surgeon?
So, the X-ray tube, it really depends on how you're in the room, but on one side, the image intensifier is gonna be on one side, your X-ray table, or your X-ray tube is gonna be on the other side. So if you, from a standpoint of, let's say the surgeon is operating on this side and we're moving the equipment in on that side, and then we make this C. But then you may be on the other side and it'll be kind of reversed. So it's just from a standpoint of where you are versus where the surgeon is. So typically it's always going to be image intensifier on one side versus X-ray tube on the other side. Because if you did over, then it'll be the opposite. There's no need to do it over. It should always be like this.
Oh, okay.
Does that make sense? It's
Yes.
kind of hard. It's kind of hard to explain with pictures, but did I answer your question? Did that make sense?
So the C will always be under the patient, not over the
Yes, the
patient.
C will
Right.
always be under the patient.
Okay.
There's no reason for the C to be over the patient. I've never, in all my years of X-ray, I've never seen anybody use it that way. It's always the C. Now, maybe if it's something with the table, something like that, but I've never seen it used the other way, the opposite way.
Okay, I understand. Thank you.
Okay, you're welcome. So we stand next to the surgeon. So no, you won't be standing directly next to the surgeon. Usually in cases like this, if this needs to happen, the surgeon is gonna move out the way. But if you and you may do this. Sometimes you do it with neuro cases. So like with C spines or L spines, when they're doing spine work, you may have the machine like this and the doctor may be on, either this side or that side working. Now, typically they don't want to be close to the tube, because being close to the tube is going to mean they're going to be, more exposure. But it's possible that they can be here. And then when we have it in that 90-degree angle and they need it, then they're going to be the ones standing right next to the patient. And we're going to be back here kind of operating if he needs us to, angle or do something like that. What will exposure to us as technologists look like in this scenario? So your exposure is going to be greater at your X-ray tube. So if your tube is going that way, so you're creating X-rays and it's going that way. It's got to go through the patient. So you're going to be probably more exposure is going to be anybody closer to that X-ray tube. And if you're not 6 feet away right here, it's going to come over your way. Does that make sense? Your exposure is always going to be greatest next to the source. So if the surgeon, for whatever reason, was operating on this patient and he was operating on this side and he was standing next to that tube, he's going to get a big dose, which usually the surgeons do have some education in radiation, so they know what's the best place for them to stand and to reduce their dose. And even some surgeons, they're good about stepping back, even with lead on. So. All right. Any other questions? Can I share this lecture in week 1's lecture? For download, as of now, it's only for viewing. I'm not sure what you mean. So all the information that I provided like last week and this week, it's the same slides that's in there. Some of the stuff I kind of condensed to kind of help, I thought maybe if I kind of condense it, it'll help you understand a little bit better. But all the slides are in the course. And these are the exact same slides. I just hid a couple slides, but they're the exact same slides that are there.
Oh yeah, I'm only saying because on usually we can download the Zoom lectures for viewing. And you've done it before in the other class. Right now it just shows we can only see it. We can't download it.
You talking about for week 1? So it's not there for week 1?
No, it's just there for viewing. Week 1's only there for viewing. I like to download them and then I can watch them throughout the week on my free time.
Oh,
And then I usually do that for every class. I know I used to do it for your class before and the other class you had. So I don't know if it's a setting you have off.
Yeah, I'll go look at Zoom, because sometimes when Zoom updates, it'll kind of change settings.
Okay.
So I'll go
Yeah,
look.
no, that's the reason I was asking, just because I